We're going to take questions after Dr. Reau's presentation. I'm going to invite Dr. Nancy Reau, who is with the University of Chicago. We're very glad to have you here. And Dr. Reau has extensive involvement in her role as president of the board of the American Liver Foundation, Illinois chapter. So welcome, and we look forward to your presentation. Thank you.
No. Thank you so much, and I want to thank Dr. Kim and the organizing committee for today's conference. I'm a little jealous of Dr. Ahn, who gave such an amazing talk, and that there is actually data for his topic. So today I'm going to be concentrating on viral hepatitis C, and there's certainly an explosion regarding therapeutics and information for hepatitis C. But when we try to now focus this on the Asian community and the Midwest area of our country, I found that I was also looking at a lot of census data with not a lot of actual information that was useful. So that I learned a lot, but not a lot for our discussion today. As a simple introduction, hepatitis C is very publicly aware now because of the changing therapeutics. It involves about 3.2 million people in the United States. A large number will die of the disease, but it's a small number of the total population, 1 to 5%. But that's still about 10,000 deaths a year. And because hepatitis C, like hepatitis B, is a gradually progressive disease, and without a change in the ability to impact the rate of disease progression, we do expect that this disease will continue to worsen. And the estimate is that by 2030, nearly 35,000 individuals will be dying a year from this. It is forecasted to continue to be the leading cause for liver transplantation, a large impact on liver cancer rates. But the good side of this is that hepatitis C therapy, unlike hepatitis B therapy, can cure this disease. So that once effective therapy is given, this disease is no longer in the host. This is strongly linked to decreasing the chance of risk for liver cancer, transplantation, cirrhosis, decompensation, so that we can impact not only whether or not you have a disease, but the most important thing, which is the long-term outcome of having that disease. But we have to identify those before they have significant injury. Otherwise, we can't impact that mortality curve as well. This is just a simple picture of the natural history. Acute hepatitis C is not that common now because, as I'll show you, we are much better at recognizing the risk factors and preventing that. However, once a person is exposed, most individuals become chronic carriers, 85%. Of those, about 20% will develop cirrhosis, and as I said, this is a slowly progressive disease. So over time, about a quarter of them will go on to develop liver cancer or decompensated cirrhosis, which can lead to transplantation or death. That's only 4% of the total population, but it has a very big impact because hepatitis C is a common disease. This shows that impact, so that the big blue bar, and I don't know why I chose to put this on the back of a blue background, very blue at that moment, but the big blue bar is the number of individuals developing cirrhosis over time. You can see that this is increasing with each decade. The orange bar is those that have decompensations, when their cirrhosis actually causes symptoms, and that is also increasing and will continue to increase unless we impact the trajectory of those infected. This is the best slide in the entire deck. This is the milestones in therapy. And this shows that when we originally discovered hepatitis C, and actually before we knew the label of hepatitis C, still called it non-A, non-B, interferon therapy was only able to cure about 6% of those infected. Now, today, we have therapy that is able to cure about 70% of those infected. And over the next 5 to 10 years, we anticipate getting rid of the therapies that have so many side effects and being able to give oral combinations of medication that can cure this disease. Kind of like taking, I've heard it compared to a Prevpack for H. pylori, that you get a package of pills and your hepatitis C will be gone. Although, as a hepatologist, I worry a little bit about job security. You could ideally imagine that a primary care doctor or even your dentist could prescribe this successfully. Nothing wrong with dentists. This is also a global disease, and the WHO estimates that about 123 million, or 2% of the world's population, has hepatitis C. You can see that I broke down a few countries because this map of hepatitis C is very superimposable across the map of hepatitis B. And in absolute figures, most of our hepatitis C infected individuals do live in Southeast Asia and the Western Pacific area. This is just that map again, very similar to a hepatitis B map, showing that the dark green is the places where the incidence is highest, prevalence is highest. In the United States, it is still a very common disease. The overall prevalence of antibody, which is exposure, is about 1.6%. Those that have active virus, which is active disease, 1.3%. And then we can profile. So we can narrow this spectrum to know who is more likely to have hepatitis C than others. It's 2 times more common in men, more prevalent in non-Hispanic blacks, 3%. And most of the individuals that are recognized, as Dr. Ahn explained, that this is through census data and the NHANES data, were born between the age of 1945, the years 1945 and 1964. And you can see the picture on the one side shows that. This is the good side. The incidence is monumentally decreasing. That's because of universal precautions, the recognition that this is passed on through exposure to infected blood, behavioral modifications, and although the incidence continues to plateau now at a very low level, the disease burden will increase at least until 2015 to 2030. Traditionally in the United States, most of our infected individuals were exposed through IV drug use. So the transmission is through exposure to percutaneous exposure through infected blood or body fluids. So although sexual transmission and vertical transmission from your mother or close contacts is possible, the vast majority of the infected individuals in the United States acquired this through IV drug use. Because of that, the CDC has always recommended risk-based screening. So we anticipate this slide to change, but up until now, if you look at the risk factors and who should be screened for hepatitis C, it is those that have an increased recognized risk, mostly through IV drug use, exposure to infected blood products or organs, high-risk behaviors. How do we do? This is not a good slide. This shows that although it's prevalent, we do a terrible job in recognizing those that are infected. 70%, 3.5 million individuals are felt to have unidentified hepatitis C. Of those that of the total population, those that are both identified and treated are only 12% of the pie. So that although these recommendations have been around for a while, it's not a very successful way of identifying and then treating those that are infected. Well, why is that? The first thing is that hepatitis C, like hepatitis B, is asymptomatic. They call it a silent killer. 40% will have normal liver enzymes, so that if you don't recognize your risk factor, we're not even going to have a blood test that easily identifies you. It's highly prevalent in groups with limited access to medical care. Universal screening is not recommended. It's been risk-based. And what do we think about these risk factors? Well, first of all, it's very difficult at a primary care appointment where you have 25 things, which include smoking cessation, obesity, discussions, controlling of your blood pressure, and diabetes, to talk about risk factors and screening for hepatitis. These invasive questions are difficult to ask, and I have to admit, as a hepatologist, where I ask difficult questions all day long, at least once a month someone can still surprise me. So that these are things that we don't always feel comfortable discussing, and when we open the door, we don't always want to be through the door that we've just opened. And then patients may not be forthright. I mean, you might forget conveniently something that isn't causing you symptoms and is a behavior that you don't feel very proud of. This, however, is the new push for screening, so that we anticipate that the CDC will recommend birth cohort screening, so that we think that we'll be able to identify more individuals if we screen those that are most likely to have been exposed to the disease. This is a kind of messy slide, and it looks expensive. You can see that the orange little blip at the bottom is what we currently do, risk-based screening. It doesn't identify very many people, but of course it's not very expensive since we're really not finding them. The no screening, of course, doesn't identify people until they cost a lot with end-stage disease. If you look at the green line, this is, at the time of this publication, this is identifying, screening those that are in the birth cohort, and then treating them with standard therapy at that time, which would be pegylated interferon and ribavirin. And although this looks expensive, this is about the same as screening an individual for hypertension and treating their hypertension. So it is really particularly cost effective. If you now look at what we consider the current standard of care, that's the blue line. That's treating a person with those two medicines as well as the third agent that was just improved and increases efficacy. Although this looks even more expensive, this is actually comparable to screening an individual for high cholesterol and treating their high cholesterol. Although maybe now that Lipitor has gone generic, that won't be a good comparison. Still, this is not going to identify everybody. Who's left out? Well, we recognize that there is disparity in liver disease. The Institute of Medicine in 2003 reported racial disparities in healthcare utilization and quality of care. African Americans have a higher risk of mortality from cirrhosis than non-African Americans, and these trends are now more recently recognized in the Hispanic population. The NHANES database, which is already a flawed database, showed a 2-time prevalence in hepatitis C in those that are African American. On top of that, there's variations in disease presentation, there are disparities in referral for treatment, and there are disparities in liver transplantation, so that even if we identify individuals, they don't always get the care that we would like them to. We recognize that there's also changing epidemiology. In high-income countries, I told you, it's IV drug use that is the typical risk factor associated with this. But this is changing. We now recognize 2 very important groups. First is men having sex with men. That's because of the HIV scare. This is now something that is no longer felt as disease transmitting as it used to be. And then migrants from high endemic countries. And as I showed, that the Asian community, or the Asian countries, do have the largest group of hepatitis C prevalence. So you would expect that your immigrant population would mirror the country that they're coming from. This is about the best slide that I could find for incidence or risk of any population that's broken down in any other way besides white and non-white, or black, non-Hispanic. And this shows that Asians really don't have too much acute hepatitis C. Well, that's not surprising, since today not very many people have acute hepatitis C at all. So what can we learn from what we know? Well, there are a number of ways of looking backwards. And anytime you do research backwards, it's always flawed. So we do recognize that Asian Americans are more likely to, wrong slide, are less likely to have an increased ALT, so that for some reason Asian Americans will typically have a lower ALT than other ethnicities, so that the one thing that we might have recognized them by might actually be lower than what we expect in this group. When you look at, this is a study that looked at a group of patients with hepatitis C, already identified hepatitis C, because it was carried out in, I think, California. A quarter of them were Asian American. When they looked at this group, they found that the vast majority were foreign-born. The vast majority or more of these individuals than other ethnicities denied risk factors, and when they did find a risk factor, as opposed to the other groups, acupuncture and blood product transmission were the 2 highest, so that they are a little skewed from what we would typically ask about. What else can we learn from? Well, Dr. Kim has been instrumental in doing hepatitis B screening in our Asian communities in the Midwest. Some screening has actually included hepatitis C screening. I pulled 3 examples. One is from a VA system, one is from Texas, and another is an antenatal population. They found that in these skewed populations, the first is 322 Vietnamese individuals in VA, not in a VA, but in Virginia, that very few of them actually had hepatitis C. 2.2% had anti-hepatitis C antibody, and that doesn't necessarily mean that they all had active virus. In Texas, a very small group, 118 Asian individuals, about 15.4 of the Vietnamese had hepatitis C exposure, whereas the overall prevalence was 6%. Probably the best reflection is the antenatal population, looked at 3,500 samples, and they found that overall less than 1% had anti-hepatitis C. However, there were no Asians with hepatitis C, but there were also very few Asians in this sample study, and very few of them were immigrants, so that we really have difficulty understanding because we've not looked. And in the small groups that we've looked in, we don't see a lot, which doesn't really give you very much positive feedback for looking further. Dr. An talked a lot about liver cancer. So we know that hepatitis C and hepatitis B can impact liver cancer, so let's look at Asian populations with liver cancer. Liver cancer risk might be higher in Asian individuals, that's been suggested. But in Asians with hepatomas or liver cancer, most of it is driven by hepatitis B, whereas in other ethnicities, it's hepatitis C driven. In the individuals with hepatitis C that are Asian, they're often co-infected with hepatitis B, which I think probably masks any contribution that hepatitis C has. It's very difficult to understand which of the diseases is more prominent if there are markers for both. Well, we know what the Midwest is, and I will go through very quickly these slides because they don't contribute too much. This is my census work, and I thought I would get credit for it, even though it doesn't inform us of very much. In the Midwest, we do not have the largest Asian population. We're the smallest of the four. On top of that, our Asian Indian population is larger, and that is an intermediary risk by the WHO, so that it is not as high as some of the other areas. Still, as Dr. Ahn showed you with the liver cancer rates, this is the Midwest Illinois data for 2003, and it shows that number 11 for cause of death remains cirrhosis and liver disease. And this is almost unchanged when you look at 2008. This is probably why, though. This is the census data for our Black or African American population, Black or African American, so that we have a larger percentage in a group that we know has a lot of hepatitis C. So that it'll be a little difficult to understand the Asian contribution until we start looking. And I'm hoping that this is a good place to start in the outreach to identify hepatitis C in our Asian Americans. Once we identify that, as it's been brought up already, it's going to be difficult to get access to care. And this is just one example. This is the Project ECHO, which was published in the New England Journal recently. This is a model that was developed by the University of New Mexico, where they took what we consider tertiary care support out to the community, so that it worked very well. They taught the primary care doctors or the health care providers in the areas where they did not have good tertiary care. They made sure they had mentorship, and then these individuals treated hepatitis C, and they found that they did a very good job at that. So although this may not be a perfect fit for every indigent population or population that doesn't get adequate access, it is a suggestion that we can be creative and get good care to individuals who have not previously had access to care. So in summary, hepatitis C is prevalent. The disease burden is expected to increase. Identifying those before they have advanced disease is imperative. We do anticipate birth cohort screening, but this is not going to be able to identify everybody with hepatitis C, and that those with limited access to health care are going to be most likely to be affected. All right, thank you so much.
Thank you so much to Drs. Reau and Ahn. We have a few minutes for questions from the audience, so if there are any questions for Dr. Ahn and Dr. Reau, this is your opportunity to ask them. Okay, don't all raise your hand at once. Are you sure? Yes. Stand up. Sure. And speak up.
Hi, my name is Delisha Kinney. Hi, everybody. Good morning. I had a question about. Okay, my question to you was for Dr. Ahn.
Yes.
You gave us some statistics about the Asian population as far as who presents with viral hepatitis. But you didn't. I wanted to ask what percentage of the patients present with liver cancer with less than 5 centimeters. How many people? How early in their prognosis do they present?
So the question was specifically among Asian Americans, what percentage of those people present with a very resectable or intervenable type of liver cancer? And unfortunately, I don't have that very detailed enough data to tell you. What I can tell you is that kind of an overall larger non-Asian American focus that Dr. El-Sarrag had a paper out several years ago that showed on review of the Medicare data that unfortunately what they found was that of the people who were diagnosed with liver cancer, only about 10% of them were offered liver transplantation. Out of, let's say, if you had 100% of those who were identified who may have been potentially liver transplant candidates, only about 10% of them were offered liver transplant. And only about 30 to 35% of them were offered resectable therapy, even though they were on retrospective review of this Medicare data, resectable or treatable with a curative intent. So I'm kind of turning the question back to you because I don't have that granular level of data to answer for you what percentage of Asian Americans comes to you with resectable or transplantable disease. Perhaps Dr. Reau or somebody else in the panel can answer that, but I'm not aware of something on a nationwide scale that breaks it down into Asian Americans to be able to answer that. Reau?
I could add to this that there have been a number of studies that have shown that if you have identified disease and you're in a screening program, that the majority of liver cancers are identified at a time when resection or therapies, curative therapies are still available. As opposed to a person who presents with liver cancer without having pre-known liver disease, that population almost always is found at a time where curative therapy cannot be offered. So independent of ethnicity, knowing that you have the disease and understanding the risk of the disease allows you to get curative therapy.
And I think that just goes to the inability, it goes to show you that we still have a lot of work to do with diving into the level of data to be able to answer those kinds of questions. So that's a very good question, but unfortunately I don't have access to that data because, again, that's a very small spot out of the whole. And we still have a lot of work to do in the whole as well, as you saw today, with identifying people at risk. We don't even know who exactly has hepatitis B and hepatitis C. We think that probably 2/3 or up to 75% of them are undiagnosed. And if you take from that undiagnosed population who are going to develop liver cancer, you're going to have a population that's at risk of presenting too late because the cancers are often too large to spread. Yes.
Thank you both. My question is actually for both of you. For hepatitis B and hepatitis C in asymptomatic individuals, at what interval is ultrasound screening recommended for cancer screening?
So that depends a bit on the disease state. Every person with cirrhosis, imaging is recommended at 6-month intervals. For hepatitis B, it's broken down by sex and age. Really, they try to stratify those that are highest risk. So most men are recommended to be screened at the age of 40, women at the age of 50, and individuals who came from Africa, screening is recommended at 20 because that population develops cancers earlier. And these are not, don't write these down. This is all very well published. You can easily find it in several different forms of practice guidelines.
And I think there's still some controversy with regards to ultrasound plus blood test as well. But the American Association for the Study of Liver Disease recommends every 6-month ultrasound based on good data that shows that as opposed to 3 months versus 6 months, 6 months is just as good and that you don't lose significantly in terms of identifying early cancers. And as Dr. Reau said, there are gender and race-specific guidelines with regards to following up hepatitis B patients, for instance. At what age do you start looking for liver cancer? Okay, thank you.